And our topic of today is there a need for oocyte cryopreservation, the psychological viewpoint? Sofia.
Good morning. Thank you so much for the invitation to speak here today, and congratulations also for this innovative event. So I was asked to try to answer the question if there is a need for oocyte cryopreservation from the psychological viewpoint. And the first thing I would like to say is that, as some speakers already also highlighted, that there is almost no data on the psychosocial aspects of oocyte cryopreservation. So to answer this question, I will try to answer it indirectly by answering these 4 questions. So who will use oocyte cryopreservation? Why and how will it be used? And can oocyte cryopreservation help women or couples to reach equipoise regarding their parenthood goals? And also, what are the psychosocial implications of using the technique? However, before going into the questions, I would like you to bear in mind a more kind of broad perspective that I would like you to have during the talk. So this is a model about reproductive decision-making that was developed in a collaborative network that brought together experts from different fields, including Guido Pennings and Thomas Sobokta here, present today. And what the model states is that almost everyone has a child wish, so desires to have a child at some point, and depending on the intensity of this child wish, people will start to think about what are their preconditions to have a child, and they will start to work towards filling that preconditions, which of course may vary. And then when they have them, they feel that they are ready to conceive, and they will try or stop avoiding conception. And then we know, of course, that some will just conceive naturally and others would need medical intervention. So people will do this at different paces because there are lots of factors that influence their decision-making, but the aspect here is that we have to think about how having the possibility to freeze eggs at this point will influence the decision-making of couples and pull them towards all these points until they eventually achieve parenthood. So our first question, who is using oocyte cryopreservation? Stoop just talked about it, and we know it's very clear that it's older women with a high education level that do not have a partner. They just found out about the technique, so that's why they're using it, and they're using it to, most of the times, to just buy them some time to find the right partner to then conceive. And some are willing to also to ponder single parenting, but many of them are not. So, but who will use oocyte cryopreservation in the future? Well, a significant number of women say that they would consider paying to store their eggs. The percentage varied from 23 to 46. But then a study with more than 3,000 American women who inquired about the technique showed that only 4% of them really used it. So there is a gap between considering use it and really using it. And the amount of women who use it may actually still be quite low. So also Stoop also showed us that the profile of the potential users are, so these are future potential users. They are younger, in their 20s, they are not married, they work and have a high income, so probably they can afford the technique, and they either don't have children or they still have a child wish regarding of their parenthood status, and they do find it acceptable to have children after 35 years of age. So basically, apparently we have 2 different types of potential users. we have an older woman who would be older than 35, currently about 38, as we know. They don't have children, they don't have a partner, and they're approaching the end of their reproductive life, and the issue is that they do not accept childlessness. And then we would have a younger woman, Mary, who is about in their 20s. They don't have children also, or they have a child wish, and they consider that late parenting is acceptable. So clear two different profiles of users. So, and what we can see here when we think at kind of the stage of reproductive decision-making that they're at, Sarah is the reason why she's not trying. The only reason is because she doesn't have a partner. But Mary, she's really not at a stage where she can have really opportunity to make decision-making here. But Mary, she's at a stage where she has a considerable high child risk, at least to ponder using or preserving their fertility, and they're at a stage where they can ponder and make plans for the future, considering and think about how oocyte cryopreservation can help them, and if it helps them achieving those parenthood plans. So, and what are those parenthood plans? So for older women who really cannot make a choice anymore, they wish that they can use oocytes soon, so around 41 or around 43. Those women who are in a condition to make a choice, so in this sample of more than 3,000 women from Canada, they think that the ideal age to have a child is around 27, but they anticipate that maybe they will only have a child around 32, and consider that the latest age for a child to have a child is around 41. So, and as was highly highlighted here by Thomas, people already anticipate and accept the idea of late parenthood, and that's what the trends show us. And so this would, in a way, explain their motivation to use oocyte preservation. However, when we look at the knowledge they have about the technique, in a way it's at odds with that motivation, or with that possible motivation. So again, in our sample of Canadian women, when 90% of them believed that until menopause, IVF can assist most women to have child using their own eggs. And only half of them believed that oocyte cryopreservation can prolong a human's fertility. So I would think that this is a odd result. And also, Stoop also find that willingness to use is not associated with knowledge of reproductive decision-making. So this lack of knowledge is strange when we think about the possible motivation to use the technique. But it's not strange when we think about the overall knowledge that people have about infertility or fertility-related issues. So this was a study that was conducted at our lab in Cardiff with more than 10,000 people from 18 different countries. And we assessed people's fertility knowledge mostly based on what are the indicators for lack of fertility, usual misconceptions about fertility, and also basic facts like how long should you wait if you're not conceiving to get medical help. And so what we see is that the overall knowledge is quite modest. So in a scale from 1 to 100, it's 57%. And we also see that knowledge is higher in more developed countries than less developed countries, and women have higher knowledge about fertility than men. So there is a general knowledge about fertility and how age and fertility are linked. What we also know is that in those couples that are trying to conceive for more than 1 year, and so are infertile already, only half of them actually seek medical help, a few more than half. And then from these that seek medical help, 20% of them actually wait more than 2 months to seek that help. So the overall scenario is that people have poor knowledge about fertility. They do not seek help and, when they need it, and if they do, they take a long time to seek it. So one has to ask, you know, it's very easy to ask if people do not seek help when they need it, why would they seek help in advance? And that demands a high degree of advanced planning and thinking about your fertility that requires also high knowledge. So why would people really think about freeze eggs early in their lives? And that may explain the 4% that we saw previously. So because of this scenario, many health professionals start to think that actually we are at a point where people need decisional aid to think about their parenthood plans. They need to start to think about them early in their lives and to really ponder and think about how they value the idea of having children, comparing with other possible life goals that they may want to pursue, their career, etc., and how and when and how many children, and so how will they draw their reproductive life plan. And we don't really know much or anything about how these tools work and if they are useful yet, but in my view, if they are making people, if they are educating people about their fertility and making them think ahead about their parenthood plans, they are on the right track. So what we do already know is that fertility aid, decisional aid to think about the possibility of fertility preservation can be useful. So in this study with 120 early breast cancer patients, 72 of them received usual care, while 48 patients received decisional aid that consisted on a booklet with information about treatments, and then at the end some tables where people could think about the pros and cons and how important those different pros and cons were for them. And so they received the decisional aid here, and they were assessed at that stage, and then 1 month and 12 months after. And what we can see is that those patients who received the decisional aid had more fertility knowledge, less decisional conflict, and 12 months later, they had less decisional regret in relation to the decision they made, that those patients who received usual care. So decisional aid can actually make people or help people to make less conflicted and more satisfying decisions about if they want or don't want to preserve their fertility for future use. So to summarize, why will oocyte cryopreservation be used? Well, for Sarah, our older women, it will be used to delay the end of the reproductive lifespan and as a way of coping with the possibility of inadvertent childlessness. And they expect to be single parents after 40 or only when and if they find a new partner. For Mary, well, we really don't know that much about these younger potential users of the technique. So the idea of using the technique to delay parenthood, their level of knowledge does not, it's a bit at odds on that, with that. So there's another possibility that is using it as an insurance against future infertility. So maybe some women already know that there is a history of infertility in the family, and they can maybe self-guard for that possibility. And when and how they will use it, well, we really don't know that much also, because we don't know when they forecast that they will be parenting. Now, our third question is if this technique can help patients reach equipoise with their parenthood goals. And so the logic of using oocyte cryopreservation is that it will help people achieve parenthood, and people with children are better off than people without children. But is that really true? Well, we are in collaboration with some colleagues in the Netherlands, so Chris Verhaak, Flora van Leuven, and Didi Brett. We did a study with more than 70,000 women from 12 different centers that used IVF 11 to 17 years earlier, and so we took in account their parenthood status, but we also introduced a new variable in the equation, that is how they cope with that parenthood status, so how they come to terms with their parenthood status. And what we found is a quite different scenario. So here we have the women who achieved parenthood, and here the women who are still childless. And in gray, we have the women who don't have a child wish, and in red, those who have a child wish. And what we find out is that regardless of having children or not, those women who still have a child wish, they have poor mental health, and poor mental health below the clinical cutoff for significant clinical problems. So it's not really about achieving parenthood, but it's about coming to terms with your parenthood status that dictates your well-being. And one has to think about how you knowing that you have also eggs frozen and ready for use may impact on your ability to really reach that equipoise regarding your possible childlessness. So the last question is, what are the psychosocial implications of using oocyte cryopreservation? Well, the first one is, of course, very known, is undergoing IVF or ICSI, and undergoing IVF or ICSI is still very demanding. So at this stage, women don't have to do the hormonal stimulation, but the period that is really challenging for women is the period where they are waiting to know about the possible success or failure of the treatment. So here is when depression and anxiety really escalates and positive effect decreases. We also know that for those couples who experience a failed treatment, here in red, these couples experience significant depressive symptoms, and especially women, here in the continuous line, and these depressive treatments who are clinically significant can continue for 6 months at least after treatment. So because of this challenging and many other challenges, around 22% of couples actually cannot undergo or are not able to undergo the 3 recommended cycles of IVF. And finally, another, of course, implication of using the technique is delayed parenthood, which was quite discussed here today already. And the study I have here, it's a study that focuses on the couple's own perceptions about delayed parenthood. And I chose this study because what it shows actually is that their perceptions fit really well with the portrait that empirical evidence gives us. And so it's a study with 46 American couples and 15 single parents who did IVF and conceived after 40 years of age. And so the advantage they see in parenthood is that they are more mature and emotional, prepared for being parents. They, of course, have more work and career flexibility at this stage, and they have financial security. A few couples, and especially women, also talked about a stronger partner relationship. And it's true that older partners are more involved in parenthood, but what the literature also shows us, and this is a quite established fact in the literature, is that marital satisfaction declines with the duration of marriage. And so older couples will be married for a longer time, and their marriage context will be less favorable. So this is quite established. And the disadvantage that they see, of course, is what we already said about having to use IVF. They also see that they will have less energy to be with their child. And in fact, many of these women will probably be menopausal or reaching menopause, and so they will be experiencing fatigue and depressive symptoms. They also see that, and this worries them, that they will have less lifetime with their children, and many of them wonder if they will be still healthy until their children reach adulthood, and if they will be alive when their children marry and have their own children, etc. And another issue that some of them point is the smaller family size. And so what we have to think here is that these women will still have a child wish, regardless of having children. And so they will be the ones in the group of women who present lower mental health, even though they achieved parenthood. And then, especially men, perceive that there is a stigma in being older parents. So these couples, in a way, they are motivated to make a positive reappraisal of their experience of being older parents. But still, when you ask them about what is their perceived optimal age for parenthood, only 10% of them say that it's at the time that they had their child. Most of them think that the early 30s are the right time to have children. So in conclusion, is there a need for outside cryopreservation? Well, for Sarah, I would say that maybe outside cryopreservation is not helpful at this time. They may take a long time to find a partner, and then many of them will not achieve parenthood using the technique. So what they really need is support to reach closure in relation to their parenthood goals. For Mary, well, in this case, I think that really outside cryopreservation may complement other ART techniques, and so it may be useful. But Mary needs especially decisional aid and education, and so that they can reach a satisfying decision of if and how they can use outside cryopreservation to follow their parenthood plan according to their expectations and eventually achieve parenthood. So my final conclusions is that decision-making about outside cryopreservation is really very complex. It requires knowledge about fertility and treatment. It implies planning in advance to achieve reproductive goals, which we kind of saw that people do not do. And also, it has multiple psychosocial implications that need to be taken into account. In my view, future research should really try to concentrate on the why and how these, especially the young possible users, will use outside cryopreservation, and we should try to profile different types of users. So maybe those who are using it to delay parenthood, or those who may be using it as a possible insurance for a possible future infertility. And these different users will have different attitudes and knowledge and motivation, but especially different needs. And if we know these needs, we can use this knowledge to inform how we can educate them and provide them with the decisional aid that they need, not only about the outside cryopreservation technique, but about the broader kind of plans and perception of parenthood. So, thank you very much.
Thank you. Questions? I do have a question. I found your distinction in profiles very interesting, because I indeed believe that we are not talking about the monolithic group, and we will see that most likely in the future when we consider the social freezes as a whole. But what I missed at the end was why Sarah should not use the technology. I mean, she was 35, so why do you think that's no use for her to consider this option?
So first, I don't think that she should not use the technique. So if I gave that impression, I apologize for that. What I think is that most of them will not reach a point where they be able to use them, because they, it takes time to find a partner and kind of came to the conclusion that that's the right person that I want to have children with. So, and they're already 38 when they're freezing their eggs. And second, when they're freezing their eggs at 38, also their chances of conception are low. So many of these women, we can expect that many of these women will not reach parenthood. And so that large proportion of women, what they, in my perspective, what they need is help to come to terms with their childless situation. And we saw that apparently they are the ones who really struggle with that. Because
that of course might be easier said than done. Trying to help.
So how can we help them reach? Yeah, so that's a very good question, and I think it's a hard question to answer also. But I would say three things about that. The first one is that it really starts when people come to treatment. So when people come to treatment, we have already to kind of present the possibility of possible failure. And so we have to advise them, we have to give information about that 1/3 of the people do not achieve parenthood even doing all recommended treatment, that actually 22% of the people are not able to do all recommended treatment. So this is a possible future scenario. And this may help people to already start preparing for that possibility, to thinking about what they can do to avoid it, but also what they can do if eventually they reach that point. The second thing that I would say is that from a psychological perspective, we know that when people face blocked goals in their life, so major life goals can be parenthood, but it can also be a marriage in crisis, the adaptive response is to disengage from that goal, if it is really blocked, and try to focus their lives in other important life goals where they can also have some satisfaction with that. And so this kind of brings me to my third point, which is that I think that when people finish treatment, when they finished a failed treatment of 3 cycles or 2 cycles or whatever, they should be counseled. And at that point, there should be kind of an assessment of what is their flexibility to focus on other possible life goals. And according to that flexibility, they could be advised to seek, for instance, support, for instance, with peer groups of other infertile people who manage to come to terms with their situations. And actually, patients say that they don't have a role model at that point where they can kind of, that can help them. And we also know that many women try to redirect their parenting goals towards other young nephews, so they find other people where they can take care of them. And also, this study also showed us that an increased focus on work can also be adaptive. So basically, I'm not saying that it will work for sure, but for many people trying to finding other important life goals where to focus can be a solution.
Thank you. There's a question in the back. I thought, no?
Yes.
Yes, Sofia, thank you for your great talk. I would like to go back to that slide about lower mental health on women wishing child.
Okay, just a second.
I think I missed something. I do not understand the slide, and I do not know how to explain it. Would you explain something else?
So, this slide, you mean?
Yeah, but
yeah, it's in my computer. Yeah, there. So, in this study, we compared these 4 groups of women. And when we made these comparisons, we took in account all the relevant backgrounds and fertility history and treatment variables. So we are controlling for all these variables. And we are investigating how these different groups of women report their mental health status 11 to 17 years after doing IVF treatment to conceive. And these were the results we found. Here are the women who achieved parenthood, and this parenthood is not only, it can be social parenthood, so adoption also, it can be through treatment or spontaneous, and here are the women who still remain, who don't have children. And some of these women, they, regardless of having children, they say that they have a child wish. So maybe those who have children, they are not satisfied with the number of children they have and want to have more, and they are those here in red, and these ones don't have children, and these women came to terms with that. They're happy, but these ones still want to have children.
Yes.
And we saw this difference. What we see is that mental health, poor mental health, is really explained by the wish to having a child. And we didn't only look at mental health. We also looked at the relationship with partner, relationship with friends, relationship with family, and their use of mental health care. And we saw that the psychosocial adjustment was always lower for women who still have a child wish, regardless of the parenthood status, and their mental health care consumption was higher. So we are finishing the paper, and hopefully, maybe you soon you may read these results. I hope I answered, clarified your issues.
Thank you.
Yeah, no.
It's okay. Thank you.
Okay.
Thank you. So we have reached the time for lunch break. So see you back after the coffee break. I mean.